So we are part of the ReSPECT rollout project from the Resource Council national-wide ReSPECT form. So I'm just going to go through a little bit about the background to the form and how it's going to work at NUH and how specifically that might work in surgery settings as well. So this is the ReSPECT plan. I'm hoping that you have seen that already or vaguely familiar with it at least. So the ReSPECT process is a process based upon one or more conversations in which there's an opportunity for patients to express their wishes, their values, their fears, things that they might want to avoid in a future emergency. And there is space for clinicians to write what care is and is not appropriate beyond just CPR. So DNA CPR really was just a focus on the act of giving a patient CPR in the event of cardiac arrest. But this is a lot more than just that. Which obviously is just as equally important when we're caring for someone in an emergency. So ReSPECT is for anyone. So you might find any type of patient will have a ReSPECT plan, but it has an increasing relevance for those with particular healthcare needs, those that are at risk of cardiac arrest or nearing the end of their life, or we do have a group of patients that would wish to record their preference for their own personal reasons. So maybe they have strong feelings about certain treatments or places of care or not coming into hospital or not dying at home, and they want that formally recorded, and that ReSPECT plan kind of facilitates all of those things. As I keep saying, it is a national-wide document, which is one of the reasons why we can't alter the content of the form, but it does also mean that there are spaces in there that are directly related to paediatric patients, because in lots of other trusts, they use it for adults and peds. Currently, we are just rolling it out in adults for NUH, but it is something that's being looked at for children as well as part of the project towards the latter end of the project. So why are we changing? So ultimately to be in line with lots of other trusts. About 80% of England and Scotland use ReSPECT, and all of our region use it. So Kingsmill, Derby, Northampton, and all of our ICS. So obviously it's in the community's best interest that we're following the same plan as they are, and obviously that's better for the patients. So we are wanting to be in line with those, and improve our conversations around emergency care planning. DNA CPR has quite a poor reputation nationally and in the media, whereas ReSPECT lands a lot better with patients. It gives us an opportunity to understand their wishes and their fears ahead of these emergencies, and thus improve communication of these set decisions. We are in week 3 of the rollout, so you may have seen us around already if you've been in any of those areas. So we've already rolled out to ED, respiratory and HCOP, and we're focusing on a different speciality every week. So our surgical wards are starting across end of October into November, critical care being at the end of October as well. Each week we are out in the wards physically replacing the DNA CPR forms, but also providing lots of kind of ad hoc teaching sessions and supporting the staff as they are writing the plans if they need that support. So that just gives you an overview of where we're going to. If we just take the next few minutes looking at what the form includes. So section 1 of the form is nice and straightforward, patient demographics. There's a space to write down how the patient wishes to be addressed, as that's often different to their name. Be aware that not to use K numbers. You can use a patient sticker, but obviously this form needs to transfer with them into other hospitals, so NHS number is better for that. So section 2 is the shared understanding of the patient's health and current condition. So, and by shared, we mean that whatever you're writing on this form, the patient needs to be in agreement with, or they understand. So we're going to really avoid abbreviations or too much medical jargon, because ultimately for a lot of patients, they're going to take this plan home with them, and it's almost their property. So they need to be able to understand what you've written about them. So you can describe their diagnosis, their personal circumstances. Just following on from that frailty, you might discuss frailty in that explanation there, but that needs to be communicated with the patient so they understand what you mean by that. You might also include things like visual impairments, hard of hearing, anything that would impact the way that we would care for that patient in an emergency, and considerations that might be needed. There's a space to record any legal documents that the patient may already have in place, such as advanced decisions to refuse treatment, and you should review those legal documents as part of completing this ReSPECT process. Identify if the patient has got a lasting power of attorney, and you can pop the details of that person on the back of the form. So while section 2 is still quite clinical, the section 3 is really the patient's space to talk about how they would describe their current health, and what they value the most in life, and what they fear and wish to avoid. There is a scale where you can ask the patient if they wish to place themselves on one end of the scale being living as long as possible, and the other end of the scale being quality of life and comfort matters the most to me. So some people really like that as a visual and they can place themselves on that. Some people don't like it at all and it doesn't resonate well for them. It's totally optional. It can just guide your conversation if you wish to. What is important is understanding what that patient values. So what do they have in their life that they is most important to them, they want to continue, or their opinions on being in hospital or being at home, whatever is relevant for that person. And then on the opposite to that, what do they fear the most? So often we see things like, I don't want to die in hospital, or I don't want to have this procedure anymore, or I come in all the time for the same thing and I'm bored of it and I hate it and I don't want to do that anymore. And those are the kinds of things that you can write there. So you can totally quote the patient. If the patient doesn't have capacity, then you can quote what their loved one is saying that their wishes were, or what to the best of their knowledge their wishes were. And then section 4 combines the clinical aspects that you've written in section 2 and the patient's wishes in section 3. So, you have your opportunity to say your piece, they have their opportunity to say their piece, and then you summarize in section 4. So you're going to decide which of these 3 care goals is appropriate for that patient. So are we prioritizing extending life? So that might be, I'm throwing everything at this person. They're going to go to critical care. They're going to be ventilated. They're going to have every surgical procedure that we've got on the catalogue. Whatever they need, we can offer them. And then the opposite end of the spectrum is prioritizing comfort, where we recognize that things just aren't in their best interests anymore. And they agree with that. And we're going to more move towards perhaps end of life planning, or that latter stage of life. And then you can be a balance of the two, which a lot of patients will fall in that balance. So we're going to offer you some things, but we're not going to offer you other things. And that's that conversation between you and the patient. There is a space underneath to really summarize that better in terms of listing perhaps things that are recommended and are not recommended. So, I'm going to recommend we do this procedure, but not anything else. Beyond that, this example I've taken from a patient record where the patient was undecided about continuing on dialysis, but for now him and his wife wanted to continue. So there's lots of extra things to consider beyond just the CPR decision. The CPR box now is at the bottom of the ReSPECT form. So essentially this is what's replaced the red DNA CPR form. A patient can have a ReSPECT plan and still be for CPR. And that's the biggest kind of take home message from all the training that we're doing at the moment. We anticipate the vast majority of ReSPECTs will be used for patients that are not having CPR, but it is definitely an option to still be have CPR recommended. So be aware of that. And then the middle box, as I've said, is just for pediatrics. So essentially you can ignore that for now. As a minimum, this box needs to be signed when you're completing every ReSPECT plan, because obviously it's the first thing you look for in the event of an emergency. On the back of the form, there's a series of tick boxes. So Section 5 is a summary of the patient's capacity assessment. If you've identified that the patient does not have mental capacity to participate in the discussions, then a formal two-stage mental capacity assessment needs to be completed, which is attached to the ReSPECT form. Then Section 5 just becomes a summary of that. Obviously, if the patient does have capacity to have the conversation, you can just tick yes here and move on, and you don't need to do anything more than that. If the patient doesn't have mental capacity, then it is essential that we involve those close to the patient, whether that be their next of kin, legal welfare proxy, relevant friends or family, whoever's already been identified as that kind of special person. And that really is because we need to gauge what wishes the patient would have had and what's been important to that person up until now, and try and articulate some of their fears that they may be aware of. If you really can't get hold of anybody, this is exactly the same as DNA CPR. If you can't involve anybody in those decisions, then there needs to be a lawful, valid reason documented as to why you've made the decisions in isolation, and there needs to be a plan of how you're going to involve them at the earliest opportunity. So ReSPECT plans are a process, and they can be completed over a series of conversations, especially for our non-acute patients. So in the community or in clinics, we can see this process being started over a number of appointments. Obviously, in an acute setting, it's a bit different because things move a little bit quicker. Anyone can write on the ReSPECT plan. We're specifically targeting clinical nurse specialists, ACPs, and then F2s and above can complete the ReSPECT plan and sign in Section 7. But if it's an ST4 or below, exactly the same as DNA CPR, it does need a senior clinician to endorse it in that purple shaded box. There is a section for emergency contacts for the patient, which is really useful, to stop you having to rifle through notes if it's on the back of the ReSPECT plan, and you can pop their contact number. It's completely optional if they sign it. Some people really want to document that they've been involved in it, and some people find that it's them that's signing their loved one's life away, and it carries a lot of grief for them. So it's completely their choice. And then the review section is on the bottom of the back of the form, and you just sign that as and when the ReSPECT plan needs reviewing. That may be if the person requests it, if their condition changes, or if they move from a care setting to another care setting, such as discharge, or if they've got a ReSPECT plan in the community and you're admitting them in, you would review it as part of that admission process. Attached to the ReSPECT plan is an MCA and communication sheet. So this is what I alluded to earlier. So wherever you've identified a patient that you believe to lack capacity, that needs to be formally assessed, and that is there for you to make that a little easier. And on the reverse of that sheet is just a blank space to elaborate on any decisions, verify who was at that conversation, or anything else that you might want to document in relation to the ReSPECT plan, because obviously there's only a limited amount of space there. The ReSPECT plan itself and this MCA sheet do separate away from each other. There's a perforation down the two sheets, so you can separate them away from one another, and only the ReSPECT plan is what the patient needs to go home with. There's a variety of patient information leaflets that are available to support your conversations, and some of these will be stocked in the wards as we roll out as well. There are translated and easy read leaflets and easy read work booklets for patients with learning disabilities available on the Resus Council website. In terms of nerve centre, there's still the DNA CPR tag. And that's exactly the same, and it will default to for CPR, and you add in DNA CPR where relevant. In addition, there is also 2 new options under ceiling of treatment. So where we would identify if they were full active management, ward-based care, etc. You can still select any of those top 4 for step 2, but the 2 bottom ones, respect completed in ED or respect form completed, can be selected, and that will generate you a respect tag for the patient. That also helps us because if we know where respect forms across the trust are, we can go down and support those areas. There's the communication as step 3, which allows you to identify any outstanding tasks or what might still be needed to be completed. If the patient has got an ICD, then that needs to be acknowledged with a plan of contacting cardiology to decide when to deactivate. So how can this work in surgery? So on Monday, I went to a ReSPECT conference that had lots of different professionals from around the country and we listened to a talk from a cardiothoracic surgeon in Papworth, which was showcasing his really positive work that he's doing in rolling out ReSPECT across his pre-op appointments. So he is working with his clinical nurse specialists to get this kind of step-by-step process set up so that on the day of discharge, on the day of their operation, they've already got quite a clear plan in place of what the patient would want in an emergency or wouldn't want in terms of perhaps outcome after surgery or various potential risks that might occur within that procedure. So he's embedded it into the pre-op booklets. So the booklet that the patient takes home with them, there are some questions in there while they're thinking about their operation, also get them thinking about what they value most in life and bits and bobs like that. So it's not as harsh as getting them to think about, would you want CPR, which is obviously very scary for some people. It just gently introduces them to the principles of respect. And he's finding really positive reviews outcomes from that, and patients are really wanting to talk about that side of their care. So they have these stages before their procedure, and then on the day of surgery the patient comes in and the anaesthetist or the surgeon completes that ReSPECT plan and signs it ready for surgery. So that is a project that's ongoing at Papworth, which may well be rolled out elsewhere depending on its outcome. They're trying to get those that published as well. Upon discharge, obviously, if you've made decisions from a surgical perspective, that needs reviewing whether or not that still stands, because this plan will move with them into the community. But all ReSPECT plans should be reviewed on discharge and ensure that the CPR box is still the correct decision for the community. The patient takes the original copy of the ReSPECT plan home with them, and then the photocopy of the ReSPECT plan and the MCA sheet will go into the notes. I've already told you this, so F1s can complete under supervision, and then more senior can complete independently. And that's exactly the same as DNA CPR, so it shouldn't be too much of a change. So in essence, in a real whistle stop, that is ReSPECT.